Welcome everybody. Good morning, good afternoon, good evening. And this is actually our last webinar in the year. We are having this webinar also at a very peculiar moment for the field of PrEP. We are witnessing many changes that are happening very quickly. This is actually a meeting where we're going to discuss the situation in France, but last week there were announcements about South Africa and also about Kenya in terms of adoption of the second use of Truvada for prevention. And this is really very interesting. Another major change this year was the release of the WHO rapid guidance, where PrEP is recommended for any person at risk, and where they extend the possibility of using, extended the pharmaceutical side of this to the possibility of using other antiretrovirals, and either tenofovir alone or tenofovir with TDF-FTC, for example, or in other combinations. So that is new, and that may facilitate implementation in places where some of those combinations are already available, like Brazil, for example. But anyway, we should go straight to the theme. I was in Geneva last week, and the feeling is this is a very rapidly changing field, and many things are happening, and we have to keep discussing and exchanging ideas. So in that context, we felt it was important to present and discuss the case of France, the approval of PrEP utilization in France as part of the national strategy, because France ends up being the first European country to do this. As we know, implications in Europe are special because health care is normally part of services provided by the state, so it has considerable financial implications depending on the cost at which the drugs are obtained, and it opens another area of discussion. But definitely the way policymakers looked at the evidence and the way this decision was made will have important implications for France, and actually important implications for other countries in Western Europe. So for that reason, we not only have a speaker from France, but also colleagues from Spain, from Barcelona, who will probably comment on implications of this in Spain and in Europe. So what we have today is a seminar entitled The Inclusion of PrEP in the HIV Response in France, Context and Challenges. The primary speaker will be then Vincent Douris. He's currently the Program Officer on Quality of Life and Quality of Care at Sidaction, a French NGO and a charity that supports research, prevention, and access to care programs in France and abroad. Then, since 2004, he has contributed to the development of various sectors at Sidaction, including HIV prevention and support for people living with HIV in prisons, HIV prevention among gay and other MSM, rapid HIV testing, and outreach programs to reach most at-risk populations. Also involved in the development of projects in the social sciences. There are many other things that you can read in our announcement about Vincent, and he will speak about the case in France. And then I will also introduce now our commentors. They are Ferran Pujol and Michael Meulbroek. They work at BCN Checkpoint, which is a community-based center for the detection of HIV and other STIs for MSM in Barcelona, which is active since 2006. It's unique in its kind in Spain, and the services offered include HIV testing and also testing for chlamydia, gonorrhea, hepatitis C, vaccination for hepatitis A and B, and linkage to care and treatment for people who test positive. Anyway, they are very interested in PrEP. I mean, Spain, this has become an important point of interest, so their comments will be very relevant for us today. So just to let you know, we will be recording this session, and once it's ready, we upload it to our YouTube channel and also to our website, and send a link around via Twitter and through our listserv, so it reaches many people. And during the presentation, we'll close the other microphones to allow for better quality of transmission, but people are free and encouraged to write comments or questions in the chat window. So I stop there, and I let Vincent begin. Thanks, Vincent, for being here today. Bonjour.
Bonjour. Thanks, Carlos. Can you hear me?
Yes.
Yes. Thanks. Thank you, Carlos, and thank you, Pedro, for organizing this meeting and for inviting me. Actually, I have to say it was challenging for me. Your proposition was challenging, and it was not easy to prepare this overview on the inclusion of PrEP in the HIV response in France and on the context and challenges. Actually, my talk will be divided in 3 main parts. I don't have access to my computer.
Unmuted.
Pedro? Pedro, can you hear me?
I can hear you.
I don't have access to my computer.
Okay, so you need...
You must have access. Just press page up, page down on your keyboard.
Oh, nothing happened.
Okay.
Oh. It was okay 2 days ago, and not today. I don't know why.
Oh, don't worry. We can. If it doesn't work.
No, that's okay.
Okay,
no, that's
great.
Okay. So, okay, sorry.
It takes some time to actually. There's some delay, I think.
Okay, so that's okay. Actually, my talk will be divided in 3 main parts. First, I will present what we know about the context in France. Then I will address issues on availability of PrEP, and then issues on the dynamic of the epidemic and the question of targeting people. And then there will be open questions for the discussion, such as question or issues of communication, adherence, sexual health, and certainly more issues will be discussed. I think that everybody in the audience knows results of the HyperGay trial. Those results were presented at the CROI conference this year and published 2 years ago in the 2 weeks ago in the New England Journal of Medicine. The HyperGay trial was a double-blind randomized trial of PrEP among gay men conducted in France and Canada between 2011 and 2014. There were 400 participants, half of them in the treated arm, half on the placebo arm. 16 infections occurred during the follow-up, 2 in the TDF-FTC arm and 14 in the placebo arm. The main result is a relative reduction of incidence in the treated arm of 86% compared to the incidence of the placebo arm. As you know, this very promising result is part of a large international effort in prevention research, and it takes place in the range of results of several trials here shown on this meta-analysis published by WHO 2 weeks ago. Here, we see that despite divergent results depending on the countries and on the populations, the overall risk ratio of the trials selected for this meta-analysis is clearly in favor of PrEP. And as you know, in November of this year, WHO updated its recommendations on PrEP. Oral PrEP should be offered as an additional prevention choice for people at substantial risk of HIV infection as part of the combination prevention approaches. In France, national recommendations are regularly published and updated by an independent committee under the aegis of the National Council on AIDS and the National Research Agency on HIV and AIDS. The committee updated those recommendations this year and add a chapter dedicated to PrEP. I will briefly present those recommendations. There are some general considerations. PrEP should be included in a broader sexual health approach and be considered as a complementary prevention tool and as part of a combination prevention strategy. In particular, PrEP should be delivered with a proper counseling designed to reinforce adherence and to limit sexual practices at risk regarding other STIs. Then vaccinal status should be reassessed, especially regarding Hep B and hepatitis A. Also, the vaccines against meningococcus should be proposed as recommended. In terms of indications, PrEP should be prescribed for seronegative MSM, reporting anal penetrations without condoms, with one or more STIs in a 1 year period, who used PrEP more than once in the last year, and then who usually use psychoactive drugs during sex. PrEP is also indicated for transgender people and should be prescribed according to the same indications than for MSM. Finally, PrEP can be considered case by case for intravenous drug users who share needles, sex workers who report sexual relations without condoms and at high risk of infection, and vulnerable persons. PrEP can also be considered case by case for other vulnerable persons who report sexual relations without condoms at high risk of infection. That's to say, sexual relations with people of a high prevalence group, superior to 1%, or with intravenous drug users, or sexual relations with physical factors increasing risk. PrEP is not recommended for those different situations. MSM who report sexual relations without condoms, but not at high risk of infection. Same for heterosexual persons. Heterosexuals who report sexual relations with a person living with HIV on treatment and with a controlled viral load, and serodifferent couples who wish to procreate without any medical assistance. In terms of prescription, PrEP should be offered as a daily pill of tenofovir DF emtricitabine, and especially for MSM, or only for MSM, sorry, as an on-demand strategy of 2 pills of the same drug, TDF-FTC, before sex, then 1 pill 24 hours after sex, and the last one 48 hours after sex. As this is the same strategy than the one that was used in the IPEG trial. PrEP should be offered with a follow-up every 3 months in hospitals, in free testing centers, or other structures like sexual health centers, associative centers, after public agreement by health authorities. Finally, the experts are estimating that PrEP could benefit to several tens of thousands of people in France, and they specify that cost-effectiveness is known in high-risk populations, but that more cost-effectiveness analyses are needed in each of the considered populations and should include the availability of generics in the close future. Now, back in the past for 2 slides. What seems important to recall is the fact that those recommendations are not new in France. In 2012, the same group of experts published a notice on the use of PrEP, specifying that PrEP should be delivered to MSM at high risk of infection, and case by case to other persons at very high risk of infection. And the same year, the National Council on AIDS published its own notice with more or less the same recommendations. In 2013, and it's probably one of the cornerstones of availability of PrEP in France, was the request by AID, the National Non-Governmental Organization on AIDS. This request was about a temporary recommendation for use of Truvada in prevention. Indeed, as Gilead, the producer of Truvada, did not apply at the time at a European level for a license for the use of Truvada in prevention, the request for a temporary recommendation for use was chosen as a way to allow the use of PrEP without this license. The answer came only 3 years later, in November of this year, 1 month ago, answering to a question of a deputy at the National Assembly. The Minister of Health declared, yes, I support the publication of a temporary recommendation for use of Truvada for prevention. I decided that this treatment would be borne 100% by the health insurance. This decision will be effective at the beginning of 2016, and this treatment will naturally be provided in accordance with scientific advice, and the prescription can only be performed by specialist practitioners in the hospital or in one of CEGID. I will talk about CEGID, which are free testing centers, a little bit after. For the moment, as you can imagine, the uptake of PrEP in France is very low, but we have to consider the informal use of PrEP when PrEP is not officially available. And even if, as these two studies shows, even if this kind of use can seem anecdotic, other countries shall consider that the informal use of PrEP exists and has to be taken into account, especially for health reasons. In France, those two studies assessed informal use of PrEP. The first one, conducted in 2011, was conducted in hospitals among persons living with HIV. Close to 600 HIV-positive participants were interviewed, and 1 person declared having shared ARVs for PrEP. The second study is conducted by AID in 2014 among 3,000 participants, HIV negative or HIV interrogative. And more than 4% of the respondents have already used PrEP at least once in their life. And among them, there were more MSM than heterosexual men or women. As I said, this kind of use can be considered as anecdotic, and we don't have any more data on a larger scale. But if we extrapolate, we can figure that more than 1,000 of people already experience PrEP in France outside of a trial and outside of a proper medical support. I'm back now to availability in the close future. The access will be wider from 2016. The access is announced to be free, and that is announced to be delivered in the hospitals or in dedicated and free centers called CEGID. That means free centers for information, testing, and diagnosis. Actually, in 2004, more than 253 HIV testing centers were reported in France, and a reform is ongoing to merge those centers with other centers dedicated to the diagnosis of STIs. Currently, those centers are not allowed to deliver ARVs in prevention, especially for PrEP, but they should be allowed to do this next year, both for PrEP and for PrEP. Those centers are performing 350,000 tests, HIV tests a year, and in France, generally speaking, more than 5 million HIV tests are performed every year. The number of new diagnoses is stable since 2007. Last year, 6,600 persons were diagnosed with HIV. The distribution of the new diagnosis reveals a concentrated epidemic with 42% of MSM, 23% of migrant women, 16% of migrant men, 10% of men born in France. Here, and 7% of women born in France, and finally 1% or less than 1% of intravenous drug users. The only trend is among MSM, among who the number of new diagnoses is increasing since 2011. The epidemic is not only concentrated in certain populations, but also in certain territories. Here you can see that Paris and its region, Île-de-France, is a region which is that is highly affected, more than other regions of France. You can also see that the French Guiana, French Department of America, is also disproportionately affected. Here is an important slide which characterizes the incidence of HIV compared to the new diagnosis. Here, for example, in the blue, this light blue, is the incidence among gay men, and in darker blue, the new diagnosis. Same for other figures. What is striking here is that the number of new diagnoses is less important than the number of new cases, especially for MSM, here, and for heterosexuals born in France. It's the opposite for migrants or for intravenous drug users. Two more slides about gay men. Here you can see that the incidence is stable or decrease. Stable, for example, in this age group, in this one, decrease in this one, 35 to 44 years. And the only age group in which the incidence is increasing is the youngest, 15 to 24 years. Here is a slide, and you can see on it that gay men are reporting more and more sex without condoms. Here a line of HIV negative gay men, here the line of HIV positive gay men, with several French studies like Enquête Presse Gay, Baromètre Gay, Net Gay Baromètre, or this European survey EMIS. One slide about transgender people. At this slide, to recall that transgender people are highly affected by HIV in France and abroad, but they are a small group, a small community in number. That is, they are not very well captured by national survey. For example, in this slide, you can see that between 2012 and 2014, only 64 transgender persons were diagnosed with HIV in France. Maybe there were more classified as MSM, maybe as women, we don't know exactly. Nevertheless, we know that transgender people, and especially migrants and sex workers, are facing a huge amount of discrimination. And thinking of PrEP, we have to encourage them to be part of the game, to be played. I recall also the fact that during the trials in this part of the screen, a very few number of transgender people were included. So we have to target gay men, transgender people, certainly migrants, maybe others. My last question will be, is targeting equal selecting? Regarding migrants, they are another population disproportionately affected by HIV in France. Among people living with HIV in France and in care, 24% are born in an African country, although they represent less than 1% of the general population. I present here quickly one of the main results of the survey ANRS Parcours, conducted between 2012 and 2013. Among 898 migrants living with HIV in France, the result is here. 35 to 49% of them were infected in France. So definitely there is a room for PrEP for migrants living in France. Finally, beyond epidemiological considerations, we can also consider what people think about PrEP. Here are some results of the survey Flash PrEP conducted by ED in 2014. It was conducted online on gay website, Facebook, or HIV websites. It was also conducted during HIV community-based testing interventions for a total number of participants of 3,024. Here is the distribution of those participants. And among the total of participants, 49% of them are willing to use PrEP. 42 are willing to use PrEP in the framework of a global health service. And the intention to use PrEP in the framework of a global health service is the next one, yes, without any doubt, 11%, and yes, but need more information, 25%. Here we have a lot of effort to do to give more information to the populations. What is interesting in this slide is that the intention to have access to PrEP is quite higher among heterosexual men than among MSM, and it's also higher than among women. But women and heterosexual men are quite included in this new game to play. And here, the last slide on this study, on this slide we can see that to be an MSM is not a factor increasing the willingness or the intention to use PrEP, but the fact having no educational background is increasing the intention to use PrEP, and living abroad also increases this intention. So finally, what I want to say is about this question of targeting. Is targeting equal selecting? In the IPG trial, the number needed to treat to avert one infection in a year is 18. And this number, as you know, is highly different depending on the populations and on the contexts, as shown in this slide. We know that PrEP will be more effective in the populations of high incidence, but persons from intermediate incidence population can consider themselves to be at risk and could benefit from PrEP. And it's a way for me to conclude this part on this point. Choice matters, not only cost effectiveness, especially when analyses are conducted with price fixed by the industry. There are a lot of issues to be discussed. For example, adherence. Here is a slide of the IPG trial. Adherence is definitely linked to effectiveness, and you can see that it was the declaration of perfect use of PrEP was of 50% in the IPG trial. What will it be in the real life is the next question to answer. Communication is to be discussed too. For example, here are two examples of communication, one by a leader, HIV leader, Françoise Barré-Sinoussi, another one by participants of the IPG trial. I think, and I opened this discussion on this, can we avoid talking of a miracle pill? Can we avoid talking about cost as if there were not the reflect of a negotiation? And my last word is to Françoise Barré-Sinoussi. Actually, it's quoted here. Extending access to PrEP is not only a public health policy matter, but an imperative human right. And I thank you for your attention.
Thank you very much, Vincent. And I think now we move to Ferran and Michael, please.
Hi, it's Ferran. Let me just briefly congratulate Vincent as well as all the other friends and activists and colleagues in France for making PrEP accessible. Now we would like to show you our study, the study we presented at the last European AIDS conference last October here in Barcelona, and which is made from the data that we have in our cohort, because we here in Barcelona Checkpoint, we conduct a cohort, probably the biggest in Southern Europe, a cohort of HIV-negative men that allows us to study incidence on this group of population. But in this case, the study that will be presented by Michael Meulbroek was mainly, the main goal was to quantify, if you can quantify, yes, or calculate the incidence of risk of our clients in our center, which are thousands, around 7,000 people a year visit our center. So what we really wanted with the study is to see how many of them could benefit in a cost-effective perspective of PrEP. So, Michael, if you are ready, please go ahead.
Yes. Can you hear me? Can you see the slides? Pedro?
Yeah. Actually, yeah. Just wait, because I think when you start to use it takes time. And
your slides are on.
Okay.
Okay.
Thank you. So.
Yeah.
Okay. I want to first place thank Pedro and Carlos and Vincent for inviting us, and we want to concentrate on two aspects: where to deliver PrEP and for who PrEP would be available. So in the EX satellite debate organized by EADG and AVAC, we presented some reasons why we think that a community center would be a very good place to deliver PrEP, because persons who are HIV negative are not used to go to hospitals. Also in community centers, it is much easier to talk to peers about sexuality, about the use or not use of condoms, and about risk perception and risk reduction. Checkpoint exists for already 10 years, and there are similar initiatives in all over Europe. We have a long experience about testing and linkage to care. We have been promoting regular testing for people at highest risk, so 4 times a year, which makes it easier for people to start PrEP, as they are planned to come and check themselves every 3 months. We have introduced new technologies, point-of-care testing for viral load. We implemented STI screening, and we do community outreach and awareness, where we give information on PrEP. We have also long-term collaboration with clinics and physicians, and we have experience on patient preparedness of treatment and adherence issues. So here you can see an example in the last year where we have been doing some sessions. This is during the Circuit Festival. It's an important K festival once a year in the summer in Barcelona, where 30,000 gay men comes, and here you can see a session on PrEP. In the last 1st of December, we protested in front of the government building. Instead of a memory of people living with HIV, we asked for more concrete actions against new infections on HIV, and especially to incorporate PrEP. So the other thing is, for who will be PrEP cost effective. So we used the data of our cohort in Checkpoint that followed 9,780 persons during 6 years of period. And what we did is break down, as we has a general incidence of 2.5 per 100 persons years, we broke down this population in 3 groups. This is the group with steady partners, no other sex partners, those in an open relationship, so with a partner and other sex partners, and those who don't have a partner. Here you can see that there was positive results in all groups, but if you look at the odds ratios, you will see that those in an open relationship and those who don't have a partner has a 90% increased risk of HIV infection. So what we did, we looked at those last two groups, those in an open relationship and no relationship, and we looked about questions they asked they answered about being top, using or not always using condom use, having had an STI, and the number of partners in the last 6 months, so more than 10 or more than 20 partners. And there you can see that if somebody not always use condoms and has had an STI and more than 10 partners, the incidence rate varied between 8 and 24 per 100 persons years, and that's independent about the position of the person. So even if people declared they were only top, you can see we have high incidence rate. So this is for us an important reason, because we see a lot of times talking about MSM at highest risk, but we have to be aware that if we talk about MSM, and especially in our context, most of them are at high risk. And so my final slide I would also dedicate to the letter we was sent by the group of Europe-PrEP about principal investigators and European advocates to ask Gilead to reduce the price of Truvada and make PrEP accessible for European countries. So, and with this I will finish.
Well, thank you very much, Michael and Ferran. I think in this comment on Vincent's presentation, together with showing us some of your own data about expectations and other things taking place in Spain, in Barcelona, very illustrative of the prospects about potential PrEP utilization. So I think this is a very nice way of opening our discussion. We have about 20 minutes, so it's excellent. And my first, actually, there are a number of questions, although Tom Craig, who is among participants, has been making some comments and providing some answers, so it's excellent. It would be important to ask Vincent how this, well, he talks comprehensive sexual health services. How do they consider the concept or understand the concept of combination prevention when they talk about comprehensive sexual health services? That's one first question, and also how it would be determined who receives on-demand PrEP and who receives the daily oral PrEP, and if it's a decision of the user or of the doctor or whoever takes care of him. Okay.
Actually, I don't know what is the discussion ongoing among doctors or medical staff. There was a meeting last week of the National Congress of Doctors involved in HIV and AIDS, and all the meeting was on this issue: how can we talk about TASP to our patients? And they're not very comfortable with the issue of TASP because of the there can be a risk, what kind of situation, and so on. So I do feel that in France, medical doctors will not be very comfortable talking about PrEP, except the doctors the most involved in this topic, of course, Jean-Michel Molinar and other leaders of the HIV trial, and except of the doctors of the Checkpoint in Paris, for example, or of other sexual health centers. But this will be a big challenge to convince doctors to be in a position of non-judgment and to offer PrEP as an alternative prevention method. to talk about combination prevention is not always easy. Do people have to use PrEP and condoms, PrEP once and a condom for another occasion, with whom, and so. So all this discourse is to invent with our own words, own sensibilities, our specificities. So maybe we'll see next year what will happen in this field. For example, I conclude very briefly on the question of the issue of communication, and it's quite important. And I think we can conduct research on the way communication is, the way people communicate about PrEP. For example, in France, the general press was quite in favor of PrEP, and some of the gay leaders were against, or they have an ambivalent sentiment about PrEP. Less and less today, as you know, and as it was recalled by Tom in the chat. Mm-hmm. So we'll have to invent new forms of communication. And then regarding the prescription, the on-demand prescription is reserved for gay men only, not for heterosexual persons. So heterosexual person will be prescribed PrEP as a daily pill, not as an on-demand strategy.
But the question is, when a gay man comes, who decides if they are offered on demand or daily PrEP, or if they choose on demand, if they have to go each time they will have sex to get a prescription, or they will receive pills to use when they need, that kind of thing. Which is, those are operational aspects of implementation.
The recommendations are that PrEP should be offered with appointments to the medical doctor every 3 months. So I do think, but who knows exactly, that people will receive pills for 3 months, and they have to choose. The gay men will have to choose when they will take those pills, but they won't. I hope that they won't have to come back. I don't know, every 3 weeks or so to get more pills if they have a daily sexual activity.
Okay, let's see some of the questions. First, I think there was an exchange about ACTA Paris, and I think Pedro asked about the attitude they are showing now, and Tom Gray responded that, well, essentially things are changing, and since it has been approved by the government, there's nothing else to say. People are, generally considering this is part of the rational policy. And then there was a question which is relevant to what you were just saying about how the campaign to get PrEP approved succeeded. You're essentially describing a situation where doctors, the majority of providers, are still hesitant, and convinced about PrEP, and stating that unless something is done, the regulation won't lead to substantial implementation, because doctors won't be willing to, unless patients ask for it, perhaps. So, but anyway, that means that in spite of doctors not being convinced, officials were convinced. And so you mentioned, somebody has mentioned as well that Jean-Michel Molina, Dr. Molina, was quite active in this process. But what would be interesting of the process of approval in France that could be considered for potential implementation in other countries in Europe?
Actually, you have to know that there is no official communication, for example, from the health authorities regarding PrEP in France. There was a declaration of the Minister of Health, and Jean-Michel Molina did a really huge job to push for PrEP. Françoise Barré-Sinoussi too, and the organization AID did a great job to push for access for PrEP. And the health authorities didn't publish anything on this at the moment, even on the site to gay men and health. So when I said we have to invent our own language to talk about PrEP, I include the national health authorities to advertise, to make campaigns, public campaigns on PrEP, campaigns among gay men, among migrants, campaigns for transgender people. There is nothing for the moment on this field, on those issues.
Mm-hmm. Okay, very interesting. There's a very important question by Nicolas, and it's related to the final publication of the IPRGAY study. It states that the results cannot be extrapolated to MSM who have sex less frequently. No, so he asks whether the general recommendation for on-demand PrEP be held up without those cautionary comments. Put it in another way, he says, on average, the IPRGAY participants took 15 pills per month. How statistically significant were those data in IPRGAY from those of participants who used on-demand PrEP less frequently? No, so is on-demand PrEP protective enough among people who used, for example, once per month or twice per month, or that hasn't been analyzed?
I'm sorry, Nicolas, I can't answer to your question. I know there is a big debate between Robert Grant and Jean-Michel Molina. There was a session organized about this at the AIDS conference this year in Vancouver. And the question of concentration is a big question that I can't answer because I don't know exactly. What I can say is that in the national recommendation, PrEP should be considered, should be offered to gay men on demand, regardless of the period of sexual activity.
Mm-hmm.
That is to say, if one gay man have one sexual relation in the month, the regimen which should be prescribed is an on-demand regimen.
Yeah.
And I know there is a lot of discussion at an international level about concentration on this thing.
And Tom Craig also makes the comment that the final results of IPRGAY, the presentation of those results by Dr. Molina has been fundamental, and that he has insisted that there have been no contamination since the opening up, not since the study was opened. So this is of course observational information, but and it has value. But probably the debate continues. I have a question. Just to have you rest a little bit. Michael, your comments about Barcelona and the fact that risks for infection among people who reported to be TOPS were very high as well. How can you interpret that? First of all, maybe the table wasn't clear enough. Could you specify what was the incidence among the TOPS and overall incidence among the bottoms, or people with some receptive sex?
Yes, I'm trying to go back to the previous slide. If you, Pedro, is it possible?
Yeah, when you go back, it takes some time, I think.
Oh, okay. Well, yes, I think that if we think about the epidemic in MSM, what we see in our center is that 60% of people with HIV diagnosis didn't have an infections 12 months previously. So we know that at least 3 out of every 5 infections were produced in the, less than 12 months. So what we are seeing is an ongoing rotation of infections, and I think this is one of the main reasons why we can understand that also bottoms are at high risk. If we see lots of new recent acute infections, high viral loads means that people will have at least a high risk. I think that also in
Michael, use your page up. Use page up to see if you can get back. Page.
No, I cannot.
Page, yeah, page back. The other sense. Okay.
No, I cannot.
Okay, well, doesn't matter. Okay.
Maybe later.
Sure, go ahead.
So, so that was the question was this is a high high fire load. So this is the dynamic what we see here. I also wanted to comment on what you asked before to Vincent about what regimen to use. I think that there are two demonstration projects going on in Europe, one in Antwerp and another in Amsterdam, where participants can use one of both regimens. So it's the participant who may choose which regimen to use. And this will be giving some interesting results, because at the end it will be the user who decides what regimen is the best for him. That may be during a period daily PrEP, and maybe during another period on-demand PrEP.
Okay, well, interesting. Now, back to some of the data presented by Vincent, and part of it is questions by Roger. I think, oh yes, he asked whether people who had 4.5% of people in this survey reporting having used PrEP, whether or not in the 2014 survey that might imply or include some responses where PEP and PrEP were confused. So we weren't talking really about just PEP, PrEP, but also PEP in some cases. Vincent.
I don't know. Hi, Roger. I don't think that it can. Maybe there is confusion, but I'm not sure, because in France we don't talk about PEP. We are talking about TPE, traitement post-exposition, treatment post-exposure. So the confusion is less easy between TPE and PrEP than between PEP and PrEP. How to be sure of that? How do you want me to answer? No, I do think that people are understood what they were talking about, and it was we can have a look at the former study which was conducted in hospitals among people living with HIV. 1% of them declared having that they had ARVs for PrEP with negative, seronegative partners or friends. And 2 years after, in a different kind of setting, the participants of this study conducted in 2014, so 3 years after the first one, was conducting during HIV community-based testing interventions among people most at risk, more at risk than the general population, among gay men, among MSM, among MSM and a few among migrants, more at risk than the general population. And the way people had to answer was by questionnaires. But okay, who knows if they understood the question? I do think that they did, because we're not talking about PEP in France, but TPE.
Carlos, can I make a comment?
Sure, sure.
I think it's an interesting question of because what we see at an anecdotal level is that some guys go to the hospital to get post-exposure prophylaxis, and then from that number of pills, they use only Truvada, and they use it for PrEP.
Okay.
So maybe they went for PrEP and they used it as PrEP.
Well, actually, people, I mean, in many cases, there's a recommendation to link PrEP with PrEP. No? So I mean, some people may understand that as a continuum, but yeah, I guess it will imply that questions are improved in the near future, are made more clearly. I see that you got your slide there. What is very interesting is that incidence among people who report only insertive sex goes from 0.9 to 15.8, whereas among those who report any receptive sex, it goes from 4 to 22.6, which, I mean, it's a very interesting, but it makes you wonder many things. So I guess that deserves a lot more discussion and study. There's a couple more things, Vincent. For example, the risk of migrants. The big question is whether, I mean, if we say just migrants who half of whom got infected in France, you would have to say that it's their networks, etc. But what about whether or not some of them, besides being migrants, had other risk categories? Maybe some of them were MSM, or some of them were sex workers, or were male sex workers. Has that analysis been conducted as well? And also, in terms of the sample used to this, of course, this is seems to be a convenience sample. So maybe, well, while the numbers are small, if it's convenience sample and it doesn't reflect necessarily the distribution of people in the population, it would be better to do the analysis for separate categories rather than as a whole. No, but so if you do it as a whole, you have you control for other categories? I mean, those were I don't know if that's clear. It's a question.
No, I'm not sure to have the information. Actually, can you hear me?
Yeah.
Yeah. In the data that I have on this particular study, parcours, there is nothing about sexual orientation or being MSM or being heterosexual. There was 3 groups surveyed: one group of persons living with HIV, another group of persons living with an chronic hepatitis B, and another group with no HIV, no hepatitis B. And we have some information, but in the national survey on the diagnosis, annual diagnosis on MSM born abroad, and actually there's a few of MSM born abroad. There is more than 2,000 MSM born in France who are diagnosed in 2014 in France, diagnosed for HIV, and maybe 500 of more MSM who are diagnosed in 2014 who are born abroad, who are migrants.
Yeah. Okay. Yeah.
On the way on where people are infected, there is nothing, to my knowledge, on the sexual orientation of people.
Okay. I also realized that in one of your slides you presented that the only group where risk is incidence is increasing is the group of younger gay men, but the number of new cases is increasing in most groups. So probably more people get tested, but so you have more cases, but the actual increase in incidence is among certain groups only, I think.
Yeah, because the way people are diagnosed don't represent well the incidence of the epidemic. There can be a difference.
Exactly. We'll have to end, but I think there's one very important question, which is what do you think about the role of the price of Truvada and potential availability of other sources of this drug that are not maybe the brand name Truvada in Europe as part of something that could happen in the near future to lower prices and make PrEP more available, easier to provide in Europe. What's the situation there?
No, Michael, do you want to answer? Of course, I support the initiative you presented. Gilead should reduce the price of Truvada, but the main point is that maybe 2 years there would be quick version of FTC, TDF-FTC.
Yes, well, I think that it's an initiative. I don't think that Gilead is very much interested in the petition. But anyway, I think we have to create more awareness, because at the end, Truvada, at least at European level, will be less and less used by people living with HIV, because it will be substituted by TAF. Yeah, and so Truvada will be soon out of use in Europe. So if it's and on the other hand, they will at the end of 2017 they will lose the patent on tenofovir. So there will be the opening for generic drugs. So it's just to see if there's any goodwill by Gilead to see if for the upcoming 2 years they will be able and willing to reduce the price, at least at the level of generic drugs. And so with this goodwill, we will have a quicker access in the whole of Europe, and not only by the most the richer countries of Europe.
Right. Yeah. No, I understand they have already allowed Cipla in India to produce this drug and as a generic, and at present many people are already ordering through the internet, and people are getting this drug in many places at much lower prices. So I think it's the reality. People are starting to do it now, and maybe that's what Gilead has recognized, that they will have to move to the other drug for treatment, and this drug may remain for PrEP, perhaps. No, we don't know what they are thinking, but maybe that's their reasoning. Anyway, I think we are 11:04 and we really have to end. So it was, an extremely interesting discussion. We are very grateful to Vincent, to Ferran, and Michael, and also to all participants who made very interesting questions. And we'll be completing the editing of this video and uploading and distributing it soon for more people to have access to it. So thanks a lot. It has been an excellent way for us to complete our webinar series this year, and we'll be in touch. Thank you very much.
Thank you very much.
Okay.
Thank you. Bye-bye. Have a good day.
Bye. Bye.